I think the discussions about, well, I think I should thank you in particular, Oynike, about the way forward when it comes to screening and early detection were already very lively. And I'm very happy right now that we'll continue these discussions in the second part of the meeting. And that's the session that's going to be shared by Professor Remco de Bree. And it will be about the treatment of head and neck cancer in FA patients. Professor Remco de Bree is the head of the Department of Head and Neck Surgical Oncology at the University Medical Center in Utrecht in the Netherlands. And the floor is yours, Remco.
Thank you, Hanneke. Thank you for the opportunity to present, to lead this second half of this meeting. So we heard a lot about the precancerous lesions and screening. I think that's very important because not all FA patients get head and neck cancer. But yeah, sometimes they do, and then we have to manage that. And yeah, we know, most of us know, that's a little bit different from other head and neck cancer patients. And I want to set the podium for the next speakers when they share their experience with us with FA patients who got head and neck cancer and their experiences from Spain and France. But first, I want to say something about head and neck cancer in general, and also in head and neck cancer in FA patients. Yeah. So in general, we're speaking about malignancies of the mucosal lining of the upper aerodigestive tract. And that's mainly, as we heard, about the oral cavity, but also the pharynx and the larynx. And the other sides are very, very rare. So yeah, we don't know if FA patients develop cancer at those sites. Well, in general speaking, more male patients are affected than female patients, and their mean age is 63 years. Unfortunately, 2/3 of patients present with an advanced stage. And of course, that's more difficult to treat, and we come back to that later. And of course, the prognosis is poorer than when they present in an early stage. And this is the opposite for oral cancer and clotic laryngeal cancer, so cancer of the vocal folds, because the vocal folds, they give early symptoms, so patients can go to their doctors early, or in the oral cavity, you can see it more easily than in the pharynx. Most of those lesions, almost all, are squamous cell carcinoma, and the etiological factors are smoking and alcohol, the classic factors. And we know from the last decade that HPV is also very important, particularly in the oropharynx. There are different entities. So HPV negative tumors are from smoking and excessive alcohol use. And the incidence is decreasing because, at least in the Western countries, the people smoke less tobacco, and that, of course, that's one of the most important risk factors. The age is about 60 years in general, and as in the HPV positive, the incidence is increasing. The etiological factor is probably oral sex, and most patients are under 60 years. And there's a predilection site is in the oropharynx, and the prognosis is far more favorable than compared to the HPV negative head and neck squamous cell carcinoma. And here you see the difference. Michael Douglas had a T4 HPV positive oropharynx carcinoma. Of course, he's different from a patient who is smoking. And this is real in the Van Gogh Museum. You can see this picture. He knows already that tobacco is not good for anybody. And of course, there are a lot of other etiological factors we don't know. What about treatment? Well, you try to treat patients with less treatment modalities as possible. And the treatment modalities we have available are surgery, radiotherapy, and chemotherapy. In early stage head and neck cancer, most patients can be treated by surgery or radiotherapy. And of course, that has less morbidity than if you combine more modalities. Unfortunately, in advanced stage disease, you have to combine treatment modalities. Is it surgery or radiotherapy with or without chemotherapy, or radiotherapy and chemotherapy with salvage surgery in reserve in case of recurrent tumor? And it's difficult, and therefore we have an MDT meeting to have the right choice for that particular patient. And if we discuss those patients, we look at the tumor site, the size of the tumor, and the extension of the tumor, and we want to know if surgery is possible. If it's not possible, then it's easy. The choice is easy. Those patients should be treated by radiotherapy with or without chemotherapy. But if surgery is possible, we look at the function, and if enough function can be preserved by surgery. If not, patients should be treated with radiotherapy with or without chemotherapy, and otherwise with surgery, with most of the time adjuvant treatment being radiotherapy. Well, then about cancer in FA patients. Well, we all know there's a mutation in one of the genes involved in the FA pathway. And yeah, like previous speaker also mentioned, it's not really clear why there's a cancer predisposition, but in general, we believe that it's because of chromosomal instability and a defective repair mechanism of the DNA damage. And it's important, of course, that it's also in all cells. So not only in the tumor cell or the cell which became a tumor cell, but also in the normal tissues. And here you see the genes. Looking where the primary tumor site is if a patient developed head and neck cancer. And we focused already in the screening programs on the oral cavity, and indeed most of the tumors are located in the oral cavity, but also in the oropharynx, hypopharynx, larynx, and sometimes there's lymph node metastasis and non-primary tumor. We don't know where the primary tumor is. And looking at in the oral cavity, most of the patients develop, if they develop, of course, head and neck tumor in the oral tongue, and there are also other tumor sites less frequently involved. But of course, you have to screen the whole tumor, but pay particular attention to the tongue. Well, if we compare the head and neck tumors, general population versus the FA patients, about age, the patients who have the head and neck cancer because of tobacco and alcohol abuse, they are 60 years or about. HPV patients are quite younger, 40 to 50 years, and FA patients, of course, even younger. Then the risk of second primary tumors, it was already mentioned that in tobacco and alcohol abuse patients, it's 30%, 3% each year. So yeah, it's each year 3%. So you come to most on the mean on 30%. And those second primary tumors are located in the head and neck, the lungs, and the esophagus. In FA patients, yeah, quite often patients get a second primary tumor, and they are located in the head and neck, or the anogenital or the gynecological sites. What about the risk? And I already mentioned, there's an increased risk of a second primary tumor, or also a primary tumor, in alcohol abuse, in tobacco and alcohol abuse about 10 to 20 times, and FA patients have a increased risk of 500 to 700 times. It's 40% develop head and neck cancer at an age of 40 years, have developed head and neck cancer. And it's quite higher if they have a stem cell transplantation, graft versus host disease, after radiotherapy, and frequently HPV positivity is found in the tumors, and not only like in the general population in the oropharynx, but also in the oral cavity. Of course, we don't know exactly what it means, but HPV is probably important in these patients. So how can we decrease this risk of developing head and neck cancer? Of course, not smoking or stop smoking, not using alcohol or only occasionally. HPV vaccination, I think that's very important, not only in females, but also in males. And of course, in many countries, there's for females, there's a vaccination program, but we think it's also important to vaccinate boys. Oral hygiene is important, and therefore they have to see the dentist or dental hygienist, because the microbiome may be important for the development of head and neck cancer. And of course, screening, and we heard a lot about this in the first part of the program today. It's all about awareness, and that's for us, of course, it's difficult to get awareness for a rare disease. And there's each year there's a Make Sense campaign through Europe, and it's important that if somebody, and particularly somebody with an increased risk, has 3 weeks complaints, they have to visit their physician. Well, about the treatment, there are limitations in FA patients. For surgery, it may be important if there's bone marrow dysfunction, so increased risk of bleeding or other or anemia. For radiotherapy, anemia is also, of course, important, because then the effect of radiotherapy is decreased. And a lot of patients need an adaptation of their scheme because of severe mucositis, or they are treated with a lower dose. And chemotherapy, yeah, most of us know there is a high incidence of cisplatin toxicity. That's because of the DNA repair mechanism defect, also in the normal tissues. And some try to treat their patients with a lower dose of cisplatin. There are reports about using cetuximab instead of cisplatin or other schemes, and maybe there's a place for immunotherapy in these patients. The prognosis of HPV patients is the best, 75% 5-year survival, and of FA patients is the lowest, about 40%. And particularly if they are having a stem cell transplant. So for now, for the conclusions, head and neck cancer occurs frequently in FA patients, far more frequently than in the general population. Head and neck cancer in FA patients is difficult to treat because of these limitations. Risk factors should be decreased. And screening is important, like we heard, for early detection, because then you can do it with one single modality. And of course, that has a less morbidity than if you need more treatment modalities, particularly if you can avoid chemotherapy. And of course, there's a better outcome if you detect in an earlier stage. That's what I want to set the podium for the management of head and neck cancer. Of course, in general patients, I showed you, but more important for now is how to treat FA patients. And that brings me to the next presentations of Alba de Pablo. She will share their experience in Spain with us about how to treat FA patients. Please go ahead.
Thank you, Remco. Okay. Can you see my screen? Yeah, okay. So thank you for the organization of Europe for inviting me to this fabulous webinar and giving me the chance to share with you the experience at my hospital, at Vallebrón Hospital, with head and neck cancer in FA patients. So in our center, we follow up a total of 37 FA patients, and out of these 37 patients, 10 developed head and neck squamous cell carcinoma. The mean age of the head and neck cancer diagnosis in our series was 31 years old. There was a tendency to be more females. There were 6 females versus 6 males. And all of these patients presented the mutation in the complementation group A. Half of these patients had received a previous bone marrow transplant as part of their myelosuppression due to the FA in the infancy. None of these patients had usual alcohol consumption, and only 1 out of the 10 had tobacco exposure. HPV-16 was tested as a surrogate for P16 only in 10 out of the 26 specimens of tumors that were analyzed. And in our series, we didn't find that any of the tumors in these 10 cases, none of them was P16 positive. However, 8 patients had a previous history of oral premalignant disorders, which, as was described before, this is the main risk factor in these patients for developing squamous cell carcinoma in the head and neck. 4 of these patients had a history of leukoplakia. 3 had a biopsy confirmed of dysplasia. 1 of them had lichen planus, and 1 of them had erythroplakia. So by far, the main cancer location, as it's reported in the literature, also in our series, it was oral cancer in 10 patients. There was 1 case also of oropharynx, 1 case of hypopharynx, and 1 case of laryngeal cancer. Inside the oral cavity, even if it's described that the most common subsite was the oral tongue, in our patients, we found that there was a very heterogeneous distribution. We had 2 oral tongue cancers, 2 cancers in the hard palate, 2 in the alveolar ridge, and 3 in the retromolar trigon. If we have a look at the stage and diagnosis of these cancers, we found that there are 2 different patterns. We find that most frequently, in 5 cases, patients were diagnosed at an early stage, stage 1, but also on the other hand, we found that 4 patients were diagnosed at a high stage, at stage 4A. However, we have to say that 3 out of these 4 patients hadn't been previously diagnosed of Fanconi anemia and were actually diagnosed of FA after their head and neck cancer. So these patients hadn't undergone the screening protocol for Fanconi anemia patients, and this may be the cause why they presented with such a high stage in our clinic. There were a total of 29 cancer episodes. 3 of them were second primary tumors, but as we can see, the main bulk of the cancer episodes were indeed recurrence in our series. All of our patients were treated initially with surgery. There were a total of 26 surgeries performed in these patients, and more than half, 62%, we treated by only local resection of the primary tumor or the recurrence. In 11% of these cases, apart from the tumor resection, we also included a neck dissection, and in 27% of these patients, a big resection was performed, and also with an appropriate reconstruction, which included 3 free flaps. So let's have a look at the pathology results on the tumors that were excised and were analyzed. We all know that risk factors for recurrence are perineural invasion, lymphovascular invasion, or extracapsular spread of the lymph nodes that have been excised on the neck. And we see that there is a tendency that we don't see that these risk factors are very frequent in the tumors that were analyzed. In 10 of the patients, there were no perineural invasion. In 10, there were no signs of lymphovascular invasion, and out of 6 neck dissections, 4 didn't have extracapsular spread. So it doesn't seem that there is a tendency for these tumors to be biologically aggressive. However, we have to take care that not all the 26 specimens had a full report, so we are missing information about some of the cases, so we can't really conclude anything about this. But what about the margins? We can see that after the surgery, there was a pretty high rate of positive margins. The margins were affected by squamous cell carcinoma in 27% of the patients, and in 23% of the patients, the margins were close to the squamous cell carcinoma. However, even if the margins were free from squamous cell carcinoma, in 46% of the patients, these margins were affected or involved by dysplasia. About the postoperative complications, we found a total of 27% complications. It included 1 free flap failure, which had to be substituted by a pedicle flap, 1 chylocervix, 2 neck infections, and 1 pneumonia. 1 patient that underwent salvage surgery for recurrence in the neck, together with resection of squamous cell carcinoma in the lung, had a respiratory failure and sepsis, and sadly ended up passing away in the immediate postoperative period. However, if we have a look in general at the complications, these were patients that were submitted to big surgeries and big reconstructions, and the complications that we found are more or less the same as the complications we can find in non-FA patients that undergo these big surgeries. Also, 27% of our patients had to undergo a blood transfusion, and these were again the patients that underwent big resections and big reconstructions, and this again is quite normal even in non-FA patients that undergo these big surgeries. Of note that the patients that we operated didn't generally have any severe cytopenias, which might also contribute that we didn't find a higher blood transfusion rate compared to the general population. So what about the adjuvant therapy after the surgery? As in 6 cases, only surgery was performed, no other treatment was done. However, in 4 out of 6 cases, radiotherapy was indicated. 2 cases, there was a positive margin, and 1 case, there was a closed margin, but because they were small tumors, T1 and 0 tumors, and the patient, the site of the tumor could be easily undergo surveillance and clinical control. So it was decided that even if there was a close or positive margin, not to deliver the radiotherapy due to the toxicity, because the patient could be followed up, and if there was any recurrence, the tumor could be rescued surgically again. However, there was 1 case of high stage and also other risk factors, and here the risk of recurrence was high, and the patient was counseled for postoperative radiotherapy. But again, when the oncologist discussed the toxicities, the patient decided not to perform the radiotherapy. In 2 cases, IMRT radiotherapy was performed. In one of these cases, also concomitance with chemotherapy was indicated due to extracapsular spread, but the chemotherapy could not be delivered because the patient had a baseline hearing loss, so the cisplatin couldn't be delivered due to the ototoxicity risk. And 2 patients received both radio and chemotherapy after the surgery. So this is the table with the patients that received the adjuvant therapy. The first patient received both radio and chemotherapy. However, this treatment was done in 2005, and I couldn't retrieve any more clinical information on the charts about the toxicity or the radiotherapy dose, or if the patient was able to complete the treatment. The second patient received radiotherapy and chemotherapy. She could receive the total dose of radiotherapy planned, which was 66 grays. However, in the first cycle done with cisplatin, she developed a grade 3 mucositis, and she couldn't receive the next 2 cycles of chemotherapy. The third patient received only radiotherapy, and she could also achieve the final dose that was planned for her, 60 grays. However, the treatment had to be temporarily interrupted because of odynophagia. And the last patient also only received radiotherapy, and this the toxicity that she developed was a grade 3 mucositis, and this was dose limiting, and she could only receive 56 grays. We had a total of 16 recurrences, and as you can see, the major problem here is the local recurrence. In 15 of these patients, there was local recurrence. In 2, there was also regional recurrence, and in 2, developed metastases. The table on the right, we can see that the patients which were diagnosed with an initial stage of low stage, the recurrence was also, again, early stage, while the patients that initially were diagnosed with high stage 4A recurred with either an inoperable tumor or distant metastases. The mean follow-up for our patients was 3 years, and sadly, half of the patients passed away during the follow-up, giving an overall survival of 50% and a mean overall survival of 3 years after their head and neck cancer diagnosis. From the Kaplan-Meier curves, we can see that the overall survival at 5 years was 51% of the patients. 80% of these patients had a recurrence. The first recurrence, there was a mean relapse-free survival of 20 months, and out of these 8 patients, 2 passed away because of the recurrence, and the other 4 that survived, 67% developed a second recurrence, and this time it was much faster than the first recurrence at a mean time of 8 months. And the relapse-free survival at 2 years was only 25%. So our take-home messages is that Fanconi anemia patients should be treated by a multidisciplinary team and referred to tertiary hospitals with experience in these patients, both for follow-up and for the management of their head and neck cancer. It's important to know that Fanconi anemia patients have a completely different profile from patients that develop spontaneous head and neck cancer. They present at a very young age. They don't present the general risk factors such as alcohol and tobacco exposure, but they do present a history of oral premalignant disorders. For patients that have been previously diagnosed with Fanconi anemia during the infancy and that undergo strict surveillance and follow-up, generally they tend to be diagnosed at an early stage, meaning that the screening works. But patients that maybe have a much milder phenotype and are not diagnosed in infancy of Fanconi anemia do not attend this follow-up and tend to present at a late stage in their head and neck cancer diagnosis. The main treatment modality for these patients is surgery, and they undergo numerous surgeries during their lifetime, mainly because of local recurrence, but also because of the risk of second and third primaries. And surgery, even big resections with big reconstruction, seems to be well tolerated in this population. In our series, the mean overall survival after the head and neck cancer diagnosis was 3 years, with an overall survival at 5 years of 51%, which, as Remco explained before, in the general population with people who don't have Fanconi anemia and are exposed to tobacco and alcohol, the mean overall survival at 5 years was around 55%. And from the IFA register, also the overall survival for Fanconi anemia at 5 years was 39%, meaning that these patients tend to have a little bit worse prognosis compared to our regular head and neck cancer patients. These patients tend to relapse, in our case, 80% of the patients at a mean of 20 months, and the second relapse happened in 67% of these patients, much faster at a mean time of 8 months. There are different factors that may affect a high local recurrence. One is margins. We found out that 27% of our patients had positive margins, 23% had closed margins, and 46% were margins affected by dysplasia. The presence of multiple oral premalignant lesions and the tendency of field cancerization make it difficult to macroscopically establish the limits of the tumor during the surgery. So this might be one of the cases why we find such high positive or closed margins. And also sometimes the surgeon may have the dilemma about how aggressive should we be, because we have to keep in mind that we need to have a balance between the resection, the oncological safety of the resection, but also keep in mind that these patients are going to undergo multiple surgeries, and we have to be aware of the remaining function and quality of life that we leave these patients after the surgery. And also that in high stage head and neck cancer, surgery isn't enough, and to decrease the local recurrence rate, these patients should need to be treated with adjuvant treatment. And there are several problems in Fanconi anemia patients because of the toxicities that radiotherapy and chemotherapy can produce, which can jeopardize the end of the treatment with a total dose as an adjuvant treatment in these patients. Also, sometimes treatment with adjuvant therapy is indicated but cannot be delivered, maybe because of cytopenias, renal or cardiac toxicity, or the risk of ototoxicity, or in patients which have been previously radiated and cannot undergo more radiotherapy for the recurrence. And sometimes also, even if adjuvant treatment could be indicated because there are some risk factors, maybe the oncologist prefers to do a more conservative approach if the risk of recurrence is not bigger than the risk of the toxicity that the adjuvant treatment can produce. And I would like to give special thanks to Dr. Balmaña and Dr. Carrasco from our familiar cancer program from the Medical Oncology Department, which are the primary healthcare providers for these patients. And they very kindly, they have a very great database, and they help me with the data to be able to present our experience today. So thank you very much.
Thank you very much, Alba, for your for sharing your experience from Barcelona. Very nice presentation, thanks. Then we go from Spain to France. Arnaud Riolet, can you give your experience with FA patients who developed head and neck cancer, please?
This presentation is going to be a little bit different of everything you've seen before, because everything has been already said, stats and so on, and survey, the need for everything has been said. What we do in St. Louis Hospital is the same, but we are working very closely with all the hematologists to aim this goal, those goals, which are early detection and early treatment. When the hematologists work and see people, generally they call me if there is anything abnormal into the mouth, and I see them the same day generally, and eventually I do something the same day. The goal is to be very accurate and very fast, very quick. Everything already has been said, so I won't emphasize this once more on the abnormalities we can see, etc. But the follow-up with every patient is depends on abnormal mucosal abnormalities you see. Sometimes, and at the beginning, at the first stage, when I see people for the first time while they are young, roughly 8-10 years, it's one per year. And then if abnormalities occur, then we're going to be more aggressive in the survey, maybe every 3 weeks, maybe more often. It can be leukoplakia or lichen planus like, because generally it's not like this, or just erosions. Sometimes it's red, sometimes it's white, sometimes it's red and white. It's very difficult to have a systemic analysis. The problem is for everybody to be systemic and have a real guideline to do everything, and everything simple. And it's not very simple, because sometimes all the mouth is sick. You have nothing normal. So you have to adapt, and always adapt. The problem is, what is the most severe part? And to know that, you just have one solution: do biopsies, and only biopsies. Brushes will be, I think, a good help for everything. But for now, in Paris, what we need it's just biopsy because we don't have any brushes. So what the problem is with the people, those kind of people who had a bone marrow transplantation, they always have big abnormalities sooner or later. And what we do is just to do a biopsy. We can't let something abnormal and look at it and wait, because the problem is to be quick enough and to remove what's abnormal. That's all. And the quite simple thing is to remove what we think it's abnormal and look at the margins. That has been said just previously, the margins under local anesthesia, okay? Nothing else. Because when you go further, when you need a big surgery, etc., okay, if it's T1 N0, it's okay. With N plus, it comes big problems. So the essential of everything is the early detection. There is nothing more than this, and that's just what we do. Stats are always the same. I think I saw more than 100 FA patients. I've done surgery on under general anesthesia, just a few of them, I think less than 10, because we have been able to remove everything under local anesthesia, just like any other abnormalities with patient absolutely normal. So I think there is nothing very different from general care of oral cancer. The difference is the frequency of the follow-up, and this is the most problematic thing. In France, we have a very, should say, efficient way of healing people, so they can be able to see doctors quite quickly, and so we are able generally to do it quick and to do it fast. But the problem, once more, is the diagnosis of everything abnormal. You know this always at the same. It's a small tumor is a better prognosis, and there is nothing new like in it. Tongue is the principal location. Sometimes the inner face of the cheek, sometimes just under the tongue, but it's always into the mouth, generally into the mouth. We just have 2 cases of esophagus cancer, and with not good outcome for sure. So there is nothing really different that everything has been said before. I can't emphasize enough on the speed of the diagnostic. There is nothing really different. What can I say else? Everything has been said. All the stats has been given. The follow-up is always the same. For the treatment, the only difference in cell is we never ever do radiotherapy, because we can't never complete all the dose. The people generally can't bear the full dose, and there is no chemotherapy efficient, if I can say that. So new ways may be treated. We already know cetuximab for palliative treatment. Maybe immunotherapy are tried. We are now typing the tumor to find new markers and try new immunotherapy. But for now, it's quite new, and we don't have any result for this. So it's always the same. Detect early, treat early, remove everything abnormal, use a free scalpel, don't use laser or electrocoagulation, because you can't have any margin, and you need the margin to be sure that you have removed everything. And the problem when everything is sick, that you will always have, you will always have abnormalities on the margins. So that's why this slide is back to the early detection. You have abnormalities, and so you will come back again and again and again, see the patient. There is nothing new for now. The only thing is to see the patient every time it's needed. And the problem is when it is needed. And the problem, the other problem is who's gonna see the patient. Fortunately, in St. Louis Hospital, I'm the only one now, and so I can see all the patients very often. Sometimes I see them 6 times a year. Sometimes it's just one if everything is normal, but always the same: soon, and treat soon. That's all.
Thank you very much, Arno. Then thanks for your opinion, the French opinion on FA head and neck cancer. Then we continue with a presentation of Ruud Brakenop of the roadmap to improve treatment of head and neck cancer in FA patients. Ruud, the floor is yours.
All right. Well, one of the goals of today was also to set a roadmap or make an action list on what should we do to improve the management of head and neck cancer patients. Important to start with that head and neck cancer in Fanconi patients is sort of managed as it is in non-Fanconi patients. We use surgery, radiotherapy, although certainly cisplatin is not used. Although Alba indicated there's some other indications, but there are clinical differences, as Remco pointed out: age of onset and cisplatin toxicity, but also many similarities between FA and non-FA tumors. The metastasis and recurrence patterns are sort of identical, similar. Tumors are preceded by precancers, but it's also similar. We looked at genetic profiles by elevation analysis in the past, are also similar. The driver gene mutations, as Jos pointed out, and also as we published before, are also similar. Although the type of mutations is somewhat different, because you see the smoking or the non-smoking in the type of mutation. There has been already a bit of discussion of HPV in the chat, and there has been a lot of confusion on HPV in Fanconi squamous cell carcinomas. There was a first study of Dave Cutler, and they reported that it was major HPV caused. However, when we noted the study, we noted that it had a very sensitive level of cutoff to call something HPV positive. In fact, when you have one virus particle per 100 cells, they called it positive. And we know that's not driven by HPV. So likely the cutoff they used was much too sensitive. We did a study, we didn't report any HPV positive case in head and neck cancers, but we confirmed the role of HPV in anogenital cancers. And there was a third study of Blanche Alter, who tested 5 cases and also didn't find any positive case, and again in anogenital tumors. So I would conclude head and neck cancer, HPV does not play a major role, if at all. In anogenital tumors, about half, I would guess. So obviously HPV vaccination will always be advised, but be aware that, the first study might be interpreted with caution. So HPV vaccination will not solve the problem in the head and neck. When I made this list, I decided to make a sort of action list, and of course I knew that the Fanconi Anemia Research Fund is very active in this field as well, and have yearly meetings. So I decided to make my own action list, and afterwards look at what they figured out. And you will see that some things are shared, but also differences. And my considerations for this roadmap or action list is that it's important to realize that FA patients with head and neck cancer may present everywhere. And that's really a problem in the management. We should also focus on the treatment for cure. And very important to realize that there are general guidelines for the treatment of head and neck cancer. You cannot easily change the standard policies. And the mainstays of treating head and neck cancer are still surgery, radiotherapy, and chemoradiotherapy using platinum, which obviously cannot easily be applied or not applied at all in Fanconi patients. But that's not all. There's also cetuximab, mentioned by Remco. We have immunotherapy now, anti-PD-1, although still for recurrent metastatic, but that will move on. And there are also neoadjuvant protocols in use. So there's much more than only the mainstays. Also important is that the treatment guidelines have been established, certainly the modern treatment guidelines, on level 1 evidence, randomized controlled trials. So if you want to change that, you should do a randomized controlled trial. So if you want to change something like Fanconi anemia, obviously that will not be possible. I will come back on the issue of new drugs and a possibility for drugs that are used in the clinic is off-label use or repurposing in a clinical trial. So you can do a clinical trial for a drug that's used for another indication. But when you want to switch to experimental drugs, you're very dependent on pharmaceutical industry. These are all things to take into consideration if you want to change something to the policy. And I sort of decided that we need something now, we need something in the coming 5 years and after that. I think the most important at this moment is what Alba and Arnaud already did, is share treatment data. Treatment of FA patients is difficult, and the experience should be shared in publications. And I'm very glad that they already have a series of at least 10 patients. Toxicity should be reported. If they try immune therapies, that should be shared. It's important to share all this information. And there's also something to consider for the Europe and the mission, Hanneke. If you look at the treatment results over Europe and the 5-year survival, then you see in Finland, it's almost 60%, and in Bulgaria, it's 20%. Obviously, this is related to factors in the country, possibilities, but this is a problem that we face in Europe. There's a large difference between countries with respect to the care. And why is it so important to share treatment results in the clinic? Because we might find surprising results. I'm very keen about learning about cetuximab in Fanconi patients. This is an experiment we did in a Fanconi tumor cell model in mice. And here you see if you don't treat the tumors in the mice, and here if you give a shot of cetuximab, 2 shots, in fact. And here we compared it with radiation, doesn't do anything, but that's of course too gray. That's a very small dose. But the effect of cetuximab in this particular cell line in Fanconi was huge. So I would be very keen to learn about what happens in the clinic and whether this would be a very good alternative in Fanconi patients, as it suggests in mouse data. I think also an important issue that we could install is a multidisciplinary advisory board. Fanconi patients are difficult to treat. Live boards will not be possible, of course, but it's important that experienced surgeons and experienced physicians share their experience with others that are confronted with a Fanconi patient with head and neck cancer in front of them. I know physicians are searching for information everywhere, so it would be very good to have a sort of organized way of doing that. And I know the FAF had this on the list as well. In Europe, we have the problem of different languages. And also, one of your suggestions would be a referral to an academic center, as also Alba indicated, send patients to experienced centers. Local knowledge in the country is important. But how are we going to change the treatment, or at least make it more promising? And I think for the longer term, and we should start with research on that now, we should focus on identify and druggable genes by functional genetics. Basically, that has been done. It has been done by us. It has been done in the DEPMAP at the Broad Institute. There are a lot of genes known in head and neck cancer that if you inhibit them, kill the cells. And this is an opportunity for the future, not only in FA, but also in non-FA. And perhaps if we want to solve it in FA, we have to study non-FA as well. It will be difficult to separate that. Obviously, you can switch that step and screen for drugs that could be used. And there was a very nice paper from Jordi Serrano's group identifying inhibitors of EGFR, defectinib and afatinib, that could be used in Fanconi head and neck cancers. I'm a little bit keen to learn. I know that Jordi is in the audience, whether they really want to proceed into a clinical trial. Perhaps he wants to share that later. I'm a little bit worried because EGFR TKIs, kinase inhibitors, have been tried in head and neck cancer for many years. And you see a result here, and they were never very effective. Of course, it's possible if Fanconi background, that's different, but it's a way to consider that in designing trials. I think it would be a great asset if we could find alternative radiosensitizers for cisplatin. We know how important radiosensitizers are in the treatment of head and neck cancer, and I think drugs that can do this would be very, very great aid in the treatment. But always you have to test the additional toxicity of any drug in Fanconi background, such as in mouse experiments in Fanconi deficient mice. We discussed a lot about cancers, and we discussed a lot about screening of precancers, but screening does not give you an answer. What are you going to do to solve this problem? Jan de Visser made a strong point and said, whatever we try to treat on precancers, it doesn't work. And there has been a lot of activity in screening chemopreventive strategies in non-FA tumors, retinoids, adenosylcysteine, COX-2 inhibitors, EGFR TKIs, cetuximab, PPRs. You can find a lot of attempts, and basically they have never been implemented in clinical care. They are not effective or not effective enough. I know there are anti-PD-1 trials. And to approach this, I think we should follow the same approach as we should do for the cancers. Screen precancerous cultures for genes that could be exploited for targeting these precancers. We need new developments and identify the drugs, and if they are used in patients, you can try to repurpose them. And if they're experimental drugs, you need a collaboration with pharmaceutical industry, and they will determine the agenda, of course. Also, something to consider. In FA, it will be impossible, in my view, to do randomized controlled trials. We don't have enough patients. So if you focus on FA only, we need to come up with very clever trials to test efficacy of drugs in the clinic. Okay, and for the long term, the ultimate goal, I would say, is would there be a possibility to change the normal or the abnormal mucosa with FA defect into normal cells? We know the field cancerization issue here, you see a dysplastic lesion displacing the normal mucosa. Could we do the reverse? Could we, for instance, correct the deficiency in patient cells and try to take over the abnormal mucosa with the FA deficient cells with normal cells, reducing the risk for cancer and precancers? Obviously, this is a long-term goal, but we have in the Fanconi research groups, we have people with experience in gene therapy. Juan Buren from Madrid is active in the gene therapy field, and I know he's working on this particular issue, but of course, this is not ready in 2 years. This will take 5, 10 years or more. So in between, we need to tackle all these other issues. And I think this is my last slide for the sort of the action list for the future. Thank you for your attention.
Thank you, Ruud, for your very nice overview and your roadmap to the future, to 2026 and further on. Okay, then I want to give back to Hanneke to conclude this webinar.
Okay, well, thank you so much, Remco. While talking about roadmaps, both Unieke and Ruud have provided us with a lot of great ideas. And when I look back at this session, I think the words that stand out most are sharing and collaboration. And especially when it comes to sharing materials, sharing methods, sharing standard operating procedures, but also sharing experiences in treatment. And so I think this will be important, and we hope very much that you're willing to become a part of the FA Europe community in order to make that happen. When I look at precancer management, I also believe patient empowerment was one of the things that Eunike mentioned. And I think from the patient organization perspective, we are more than willing to help out there. Also, when it comes to stringent screening, that's one of the things that even in the last session was mentioned. How are we going to implement this? And how are we going to make sure that there's equal access to this stringent screening across Europe? That's one of the big issues as well. I very much like the pyramid that Eunike provided us with. I also love the fact that Ruud already has some sort of a time frame implemented. So we're going to try to put these together and summarize I think the most important things that came out of this meeting, and we will bring it back to you. We will inform you and we will share that with you, and then we're going to continue this discussion and also get to your work, I think, especially thinking about the multidisciplinary advisory board and how we can put such a thing together to really get to work and not only share experiences, but also help each other out in the treatment of this complicated patient group, I think is essential. So for now, actually, I just want to thank everybody, in particular the speakers, the chairs, the participants, the scientific program committee, technical support, the people of the Princess Maxima, and of course, our FA Europe project manager, Samir Aydoush, who has been really great in supporting us. And I'd like to ask you that once you receive our survey, then please fill it out and provide us with feedback and suggestions on how to move forward. Also, sign up for our newsletter. so we can keep in touch, or even better, become an active member in the FA Europe network. Thank you so much, everybody, and have a great weekend. Bye-bye.
Bye.